हेलो हेलो। ओके। हेलो हेलो यार। हेलो।
Hello.
ये मेरा क्या हो कर दिया कैमरा कहाँ कैमरा तो लगा हुआ है थोड़ा लाइट इसको तो डार्क कर दो
भाई कुछ ना बोल मत दो
मेरे को ज्यादा नहीं हटा दो।
यहाँ से म्यूट है। बार बार करते हो फिर वो अनम्यूट करते हैं।
So good evening, one and all. So I welcome you all to the second session of the NAMS National Virtual Graduated Medical CME. I would now like to invite Dr. Umesh Kapil sir, who is the Secretary of National Academy of Medical Sciences, to deliver the welcome address.
Namaskar and good evening to all. On behalf of National Academy of Medical Sciences, I welcome all of you to the second lecture series, which is a part of Navigate program. My special welcome to chairpersons, Dr. R.K. Sharma, Head Medanta Nephrology and Kidney and Urology Department, at Lucknow. My special welcome to Dr. Sanjay Agarwal, my colleague from All India Institute of Medical Sciences, who is a professor and head for last 10 years. My welcome to Dr. Rakesh Agarwal, Director JIPMER, and also he was a professor with the Department of Gastroenterology at All India Institute of Medical Sciences and SGPGI Lucknow. My special welcome to Professor C. Epan, who is a Director, Christian Medical College, Vellore, who has very kindly consented to be the chairperson of the second second lecture today. My humble submission to all the participants is, please ask as many questions as possible. And this is essentially for the students. So what can be done is that the chairperson will hand over the mic to chairperson subsequently and will request to moderate so that the active participation of students takes place. Thank you very much. Namaskar.
Thank you, sir. Now I would like to request Professor Sukumar Sareen, sir, to introduce the audience to the Navigate Medico CME program. Professor Siv Sareen, sir, is the Senior Professor of Hepatology and Director of ILBS and also the President of National Academy of Medical Sciences. Over to Dr. Siv Sareen, sir. Dr. Sareen would be joining a bit late. So I would like to introduce the chairperson of the first session, Professor Rajkumar Sharma, sir. Next slide. Next slide. Thank you. So Professor Rajkumar Sharma, sir, is the Director and Head, Department of Nephrology and Kidney Transplant Medicine at Medanta Kidney and Urology Institute, Lucknow. He is also the Director and Head of the Department of Nephrology and Transplant Medicine, former Director and Dean and Head of Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, former Director of RML Institute of Medical Sciences, Lucknow. And he has multiple fellowships, and his predominant areas of interest include the transplant immunology, critical care, and interventional nephrology. Sir is a recipient of multiple awards, including Lifetime Achievement Award from the American College of Physicians in the year 2022. And he has multiple honors and multiple publications to his credit. Over to you, sir.
Good evening, ladies and gentlemen. I hope I'm audible. I would like to thank Professor Sareen and the National Academy for starting this program, which is basically excellence in the area of education. And we have the pleasure of having this presentation for today, the first one by Dr. Sanjay Agarwal, who is actually a very senior nephrologist and a colleague. He is at present the head of Department of Nephrology at All India Institute of Medical Sciences, New Delhi, and he is has been the past chief editor of Indian Journal of Transplantation and editor-in-chief. He is presently of seminars in dialysis. He has an excellent track record of doing research in the area of chronic kidney disease and renal failure dialysis and transplantation. He has been instrumental to initiate some of the initial Indian studies and data about the problem of chronic kidney disease, which is spreading like an epidemic all over the world. So we are looking forward to hear Professor Sanjay Agarwal in this area, and I would urge that all of you should be prepared with any questions, comments, and doubts, which he would be very keen to reply to. So, Professor Sanjay Agarwal, please.
Good afternoon. At the outset, I must thank National Academy to giving a chance to me to share with you to approach of a case of renal failure. Renal failure, if it is, renal failure constitute approximately 50% of patient what we see in clinical practice. And in 40 minutes, what I will give more of a concept of approach to a patient of renal failure, rather than going into too much detail on each point. Outline of my talk is outline of my talk is concept of renal failure, changing terminology, magnitude of problem, stages of disease, causes of renal failure, clinical presentation, course, management, and prevention. Now, concept of renal failure means that there is a loss of kidney function. But then we should see that what are the kidney functions. There are three broad group of kidney function. One is excretion of waste product. Other is endocrine function, in which kidney secrete three hormones: erythropoietin, vitamin D, and renin. And the maintenance of internal milieu in terms of a maintenance of acid base, electrolyte, and fluid. Now, out of these function, once we say renal failure, we primarily means the excretory function has decreased. Although isolated endocrine function and maintenance of internal milieu is possible in some of the kidney disease, but then unless excretion of the waste function, excretory function is impaired, person is still not labeled in any form of a renal failure. Now, assessment of a excretory function is in terms of a glomerular filtration rate, and each kidney is made up of 1 million nephron, and each nephron has got a individual glomerular filtration rate, because upper portion of the nephron is made of a glomerulus, and what is filtered there of 1 million nephron in each kidney in total make a total glomerular filtration rate of a person, which in an adult is approximately 100 milliliter per minute. Now, once we explain how we measure the glomerular filtration rate, primarily it means how much of the blood is cleared in a unit time of a substance. So which means that we have to measure a substance in the blood and how much it is excreted in a unit time, and then we calculate the glomerular filtration rate of the body as such, including of both the kidneys. So this basic formula is U into V divided by P, where U is the urinary concentration of a X substance, V is the volume of the urine in minutes, and P is the concentration of same substance in the plasma. So this basic principle remains same, whatever method we use for measurement of a glomerular filtration rate. Now, there are two issues in glomerular filtration rate. One is what method we are using for measurement of GFR, and what substance or what marker we are using. So there are three broad methods. One is urinary clearance, other is plasma clearance, and the third is the nuclear method by which we can measure glomerular filtration rate. And in the marker or the substances which are used for measurement of GFR, there are inulin, creatinine, iothalmate, and there are many other. But inulin is the ideal substance for measurement of a urinary clearance of inulin, but it is a cumbersome process. Inulin is not easily available, at least in India. So what we do, we actually, instead of measurement, we estimate the glomerular filtration rate by the formula. Now this is another concept which explain what is the relationship of a serum creatinine, which is the most important marker for assessment of or estimation of glomerular filtration rate, which is on the y-axis, and the ideal GFR measurement by inulin clearance is on the x-axis. So you can see that from inulin clearance measured GFR, once it decreases from 120 to 80 ml per minute, still serum creatinine doesn't increase. Now, once it drops from 80 to 60 and then 40, then there is a sudden rise of the serum creatinine. And this is because creatinine in the blood comes from the sites where it is generated, which is primarily muscle. It is excreted from at the glomerular level, as well as it is also secreted from the tubular. And in addition to kidney, there is an extra-renal secretion from the gut. So combination of generation, glomerular filtration and tubular secretion and extra-renal clearance of creatinine actually makes this graph. Now, if you measure serum creatinine alone, it actually alone doesn't give assessment of a glomerular filtration rate. And the example is, if you take a male patient who is 80 kg weight and his serum creatinine is 1.3, if you estimate glomerular filtration rate, it will come out to be 90 ml per minute. But same serum creatinine of 1.3 in a female of a 40 kg weight, and if you estimate GFR, it will come out to 45 ml per minute. So that is why serum creatinine alone does not give a true representation or true estimation of GFR, because where it comes, how much is generated creatinine in the body, which is much more in a healthy and muscular male as compared to thin-willed female. And that is why this assessment is very crucial. So for estimating glomerular filtration rate, I'm again repeating, it is not measurement, we actually estimate. And there are various formulas, at least till now, approximately 30-35 formulas has been generated to estimate GFR. I will not go into detail, but to summarize that CKD-AP equation is currently the most acceptable equation for estimation of glomerular filtration rate. What the studies have done, that they have correlated estimated GFR from measured GFR, and it has shown there is a very good correlation of this formula for estimation of GFR and actually truly measurement of GFR. So this graph very clearly says that even for the research purposes, as well as for the clinical management of the patient in clinics and hospital, estimated GFR is still considered you can say, as a gold standard for management of the patient. Now, renal failure by definition means that the GFR is less than 60 ml per minute. Now, this as in it is of two types. One is acute renal failure, which is recent onset and most of the time reversible. Now, second is chronic renal failure, which means that the renal failure is persistent for more than 3 months in absence of a reversibility, and it has got a tendency to progression. And without saying that once a correct diagnosis of chronic renal failure is made, it cannot be cured. It can only be managed, or it can only be decreased its progression. Now, these terminology of acute renal failure and chronic renal failure were being used from decades. But lately, in last 2 decades, these terminologies has changed. So what it has changed, that the acute renal failure has been changed to acute kidney injury, and the basic diagnosis, basic interpretation or understanding still remains same, that it is recent onset and mostly reversible. While the chronic renal failure has changed to chronic kidney disease with the same understanding that it is more than 3 months in absence of reversibility. So why this change is? Now, acute renal failure and chronic renal failure term explain that the kidney function has decreased or lost. While acute kidney injury and chronic kidney disease is a broad term, even a milder degree of acute kidney injury or chronic kidney disease in early stage may not have decrease in GFR below 60. But still, both AKI and CKD has got evidence of kidney disease and or damage, but without fall in GFR. And as these both are progressive disease, that it will be a better term of AKI and chronic kidney disease, because it will cover a broad spectrum of various stages within AKI and chronic kidney disease. Now, once I wanted to give a concept of renal failure, so in next subsequent slide, I will take the comparison of AKI and CKD in continuity, so that you can better interpret that how AKI is different from chronic kidney disease. Now, what is the definition of disease? Now, AKI means sudden fall in glomerular filter GFR in hours to days, associated with rise in serum creatinine with or without change in urine output, and most of the time it is potentially reversible. So this is a broad definition of acute kidney injury. Against acute AKI, CKD means that there is evidence of kidney disease or fall in GFR less than 60 ml, which is persistent for more than 3 months. Now, what is evidence of kidney disease? It is either maybe pathological abnormality or markers of kidney damage. And what are markers of kidney damage? There is a abnormal protein in the urine or blood, and there is an abnormal imaging test in the radiology. So if any abnormality of proteinuria is there, or there is an abnormal imaging test in kidney, the person will be labeled as having kidney disease. Now, that person may or may not have fall in GFR. But as I told you, this is a progressive disease, which we will understand in next subsequent slides. Now, what markers of kidney disease is? There are 2 major tests done. One is estimation of serum creatinine. And as I explained, that by serum creatinine, we can estimate GFR. And other is urine examination for proteinuria or sediment abnormality, which can simply be done by Eurostick. We can test the albumin in the periphery in primary health center also. So if we do urine deep stick examination and calculate serum creatinine and then estimate eGFR, we will be able to label that the person has got kidney disease. Now, that patient may or may not have fall in GFR below 60, but still he will be labeled CKD, and that we will come to subsequent slides. Now, these are the common example of abnormal imaging of various types, like plain X-ray abdomen showing multiple stone, cystourethropy showing vesicularity reflex, CT scan showing chronic pyelonephritis, and a gross specimen is showing polycystic kidney disease. Now, once understanding what is AKI and what is CKD, let us see what are the stages of these 2 broad terms. Now, AKI is grouped into 3 stages. Stage 1 means that the creatinine increase more than 1.5 times the baseline or more than 0.3 milligram per deciliter. Now, you can understand the increase in 0.3 milligram is so small, but still, studies has shown that the person who has got stage 1 AKI had got a high incidence of going to higher stages of AKI, morbidity, and in-hospital mortality. Now, stage 1 is creatinine values and fall in urine output of less than 0.5 ml per kg for 6 to 12 hours. Now, subsequent stages are of a higher category, which means stage 2, rise in serum creatinine more than 2 times from the baseline and fall in urine output 0.5 ml per kg for more than 12 hours. Stage 3, AKI is 3 times rise or increase in serum creatinine more than 4 milligram absolute value and fall in urine output less than 0.3 ml per kg for 24 hours. So why here we can again understand that why the term of acute renal failure has changed to AKI. If you see stage 1, at that time, many patients may not have fall in GFR less than 60. But still, if the output is decreased and if the creatinine is increased to more than 0.3, but it still remains within the normal limit, the patient will still qualify to be a stage 1 AKI. While if we take acute renal failure as an absolute term, then probably unless patient has gone into stage 3 or later stage of 2, he will not be labeled as acute renal failure. And as it is a continuum of severity of the disease which is important, the term acute kidney injury was more acceptable than acute renal failure. Now, once we will come to chronic kidney disease, there are 5 stages of chronic kidney disease, stage 1 to stage 5. Stage 1 GFR is less than 90 ml per minute, is more than 90 ml per minute. So one can see when the GFR is more than 90, then why is chronic kidney disease? But if you go back to the definition of chronic kidney disease, there is there are 2 components, fall in GFR and evidence of kidney disease, which means that in stage 1, there is evidence of kidney disease in the form of abnormal proteinuria, but GFR is still more than 90. Now then stage 2, 3, 4 and 5 are defined on the basis of the level of GFR. So stage 2 is GFR 60 to 90, stage 3 is 30 to 60, stage 4 is 15 to 30, and stage 5 is less than 15 ml. Now what actually happens that the patient who is in stage 1, majority of time chronic kidney disease progresses with time, and person will ultimately, if the diagnosis is correct, then the person will ultimately go from stage 1 to stage 5. Stage 5 defines a stage when the person cannot be maintained on the medical treatment and he needs renal replacement therapy, which is a term which is given a combination of dialysis and or kidney transplantation. To any person who is CKD and in stage 5, we usually suggest to organize for maintenance dialysis or kidney transplantation. Now, what has been seen that the initial staging was based on the GFR only. So it was G1, G2, G3, stage 3 was divided into 2, G3A and G3B and G4 and 5. But later on it was seen that other than the GFR, degree of albuminuria is also important in terms of assessing morbidity and mortality in a patient. So then the albuminuria was added in assessing a patient of chronic kidney disease. And albuminuria is divided into 3 stages, you can say, A1, A2, A3. Now, A1 is albumin excretion less than 30 milligram per day. A2 is between 30 to 300. A3 is more than 300. So now what currently we do, we assess both GFR and degree of albuminuria. And then it comes the heat map of combination of G stage and albuminuria or A stage. Now, this is a very important slide which has got 3-4 very important implications. Number one, if we go to the lowest right corner, that is the patient, if he falls into that, he's got more severe disease. So this heat map defines the severity of CKD. Number two, this heat map also defines that which group of a patient require non-specific anti-proteinuria treatment of CKD. So the person who is in stage A3, they needs often drugs for decreasing the degree of proteinuria. Now, this heat map also defines that which patient should be followed how frequently. So a person who falls into the red color boxes, that person needs to be followed up probably monthly or 2 monthly or 3 monthly, much closer as compared to patient who fall into lighter color or the yellow color boxes. So this is another important thing is which is from a public health point of view, that this heat map also define that when a patient of CKD is being seen by primary care physician, which group of patients should actually be referred to nephrologist. So all patients which are in the red and lighter lilac color needs to be referred to the nephrologist for planning the treatment, and then primary care physician can continue to follow by that stage. So this heat map of combination of glomerular filtration rate and degree of a proteinuria is very important for assessing patient of CKD. Now, after assessing the AKI definition and stages, let's see what is the magnitude of problem. Now, this is a pooled incidence rate of AKI in various world zones out of all hospital admission, and if I only concentrate to Southern Asia, it is 23.7%. You can interpret out of all 100 admission in a hospital, 1/4 of patient will be having AKI. Now, this is a slide from a same study which is showing that out of those 1/4, what are the different stages of AKI, stage 1, 2, or 3. So you can see stage 1 is 11.5%, stage 2 is less as compared to stage 1. But it doesn't mean that the stage 1 AKI is not important, because as I told you, even stage 1 AKI has got a higher risk of in-hospital stay and a hospital-associated mortality as compared to person who doesn't have AKI. But obviously, if we compare the degree of mortality, then stage 3 AKI will have got much higher mortality than stage 2 or stage 1. So this is AKI magnitude. Now, if we come to CKD magnitude, on the left side it is the prevalence per 100,000, and on the right side is the incidence per 100,000. And this slide is showing as in relation to SDI, which is Social Demographic Index, Social Development Index, and India fall into low middle SDI. So the lower is the SDI, the higher is the incidence and prevalence of CKD. But grossly, we can say that in any population, approximately 10% adult population of a country has got some degree of a CKD, which means that anyone from stage 1 to stage 5. Now, this is global burden of disease from India data, and this is compared in different age group. And you can see as this slide says 2 messages. Number one, the prevalence of CKD is common in female than male. And number 2, as the age increases, the prevalence of chronic kidney disease increases in the country. If we take an average middle of somewhere 5th decade of life, then approximately 10 to 12% of adult population will be having CKD in the country. Now, this is from same global burden of disease, and this only try to show that the prevalence is not same across the country. It is comparing 1990 data to 2017 data. And you can see the dark red color is more than 10%. In 1990, none of the state was having dark red color. While in 2017, there are 3-4 states has got dark color, which means the prevalence is more than 10%. So it is not uniformly distributed across the country. Now, once we have seen what is the magnitude of problem, let's see what are the causes of AKI and CKD. Now, AKI conventionally is classified into pre-renal, renal, and post-renal. And in short, in pre-renal, kidney is primarily normal, but the perfusion to the kidney is decreased. In the renal, kidney parenchyma itself is affected. And in post-renal, perfusion to kidney is normal, kidney parenchyma is also normal to start with, but there is an obstruction to the urinary flow. And if you see the common causes in pre-renal, hypovolemia and hypotension, hepatorenal syndrome. In renal causes of AKI, the common one are acute tubular necrosis, acute glomerulonephritis, acute interstitial nephritis, and vascular causes, and thrombotic microangiopathic anemia in the form of HUS and TTP. And in post-renal, obstruction can be inside the lumen like stone, in the wall like any malignancy, and outside the lumen, any tumor pressing the urinary tract. So these are the broad causes of acute kidney injury. And this is showing 3 broad groups: common causes, less common, and little uncommon. And you can see the sepsis, drugs, cardiac surgery, acute hepatic failure, and a pre-existing chronic kidney disease are the most common causes. And this slide is showing the size of the circle denoting the percentage of magnitude of that causing AKI. Eclampsia, obstruction, and cancer are less common. Glomerulonephritis and thrombotic microangiopathy is in the middle. So these are, although there are a list of causes, but these causes summarizes the common causes which we see in clinical practice. Now that was causes in acute kidney injury. Again, reminding that sepsis and the drugs, those were the 2 commonest causes in AKI. Now see what are the common causes of CKD. There are 5 common causes of CKD: diabetic nephropathy, hypertension, glomerulonephritis, and tubulointerstitial disease, including pyelonephritis and cystic diseases of the kidney. But what is also important, that there is a group of causes in chronic kidney disease, which in this constitute approximately 30 to 40%, where we do not know the cause. And these patients are labeled as CKD of unknown cause, or in abbreviation form CKDU. Now, CKDU is a group of diseases where CKD is not because of the rest of the 4 or 5 common causes like diabetes, glomerulonephritis, hypertension, pyelonephritis. So these 4, 5 are not there. But that doesn't mean that the CKDU does not have a cause. Ultimately, it has to have a cause. It's only that at the moment we are not able to find the cause of approximately 30% of patients of CKD. So if you see the causes comparison between acute AKI and CKD, sepsis and drug and hypovolemia are the major causes in AKI, while in CKD, renal, out of renal, diabetes, hypertension, tubulointerstitial disease, chronic glomerulonephritis, and polycystic kidney disease, these 5 causes in combination constitute approximately 90 to 95% of cases of CKD. While on AKI, infection and drug constitute approximately 70 to 80% patient of AKI. Now, once seeing the causes of AKI, let's see what is the clinical presentation of AKI and CKD. Now, AKI, there are certain predisposing factors: advanced age, volume depletion, diuretic use, proteinuria, myeloma, pre-existing diabetes, cardiac failure, and the renal failure. Now, anybody who has got these one or more predisposing factor, AKI is more common. So in that patient of presenting with AKI, we will find one of these findings also. Now, if you see, there are three components we take in the history: the drug intake and fluid loss, or features of low renal perfusion in terms of gastroenteritis, heart and liver failure. And for acute glomerulonephritis, there is maybe evidence of systemic disease in the form of joint pain, hypertension, rash, oral ulcer. So these are the things in acute kidney injury where we take the things from the history. But then we go to examination, then post-renal AKI has got feature of a obstruction in the form of a full bladder or a renal lump. In pre-renal, we will find features of a hypoperfusion, which means hypotension, tachycardia, dry skin, or low GAVP. And in a systemic disease, we can find purpura, episcleritis, uveitis, rash, etc. So combination of a risk factor, features on history, and on examination actually makes that what is the particular cause in a particular patient. Now, on one side, we have seen the risk factor of AKI. Now we see the risk factor of chronic kidney disease. Then there are 5 risk factors: diabetes, hypertension, family history of chronic kidney disease, age above 60, and past history of acute kidney injury. Now these are the high risk group where chronic kidney disease is more common. Now if we see in terms of a presentation of chronic kidney disease, a large number of patients of CKD are asymptomatic and detected by 2 methods. One is medical checkup for insurance, and other is once we do the serum creatinine and estimate GFR in preoperative situation. And now the third, which is common, is all radiological procedure where the contrast is being used. The radiologist asks for the serum creatinine and then the CKD is detected. So that is a diagnosis of CKD in an asymptomatic patient, and it's not a small, it is a significant percentage of CKD patient. Now, second is that if the CKD is reasonably advanced, then we can have uremic symptom in the form of edema, nausea or vomiting. As I showed in one of the slides, that CKD is a risk factor of acute kidney injury. So many patients of CKD actually present acutely. And then we have to differentiate clinically and by investigation whether that patient is actually AKI or it is pre-existing CKD or AKI on top of a pre-existing CKD. Then very advanced CKD has got complication, and the common complication of are pulmonary edema, chest infection, and pericarditis. And some of the patients do actually succumb to sudden death in view of the chronic kidney disease. Now, if you see the organ-wise, almost there is no organ in the body which is not involved by the chronic kidney disease, and it will be probably difficult in short time to cover this. But suffice to say that almost every organ of the body is involved by CKD, so it's more of a systemic disease rather than restricting to kidney. Now, this is in short comparison of causes of AKI in CKD. It may be repetition, but just to suffice that AKI is hospital acquired is very common. History of drug and sepsis is common. These patients often have got acidosis and hypotension. While on CKD side, patients are often asymptomatic, have got diabetes and hypertension, and they've got more bone disease or acidosis. Now, once we have seen the clinical presentation, let's see the diagnosis and approach. Now, any patient of renal failure where we do not know obvious whether it is acute kidney injury or CKD, we see the evidence of a hypovolemia. If there is a hypovolemia, then most likely it is pre-renal AKI. If the volume of the patient is normal or increase, then most of the time we do ultrasound to see whether there are a dilated tract or the urinary tracts are normal. If they are dilated tract, then it's most likely post-renal AKI. And then we shift to the radiological investigation in terms of a plain X abdomen, pyelography or other CT scan, etc. But if the volume is normal and ultrasound is also normal or showing a small kidney, then we need to check the urine examination whether there is a active urinary sediment in form of a dysmorphic RBC or RBC cast, or it is a bland urine sediment. If it is active urinary sediment in form of a dysmorphic RBC or RBC cast, then it's likely to be glomerulonephritis, while if it is bland urine sediment, then it is most likely acute tubular necrosis. So this is the approach of suspected AKI which we follow bedside. There is one more important thing in AKI which has developed in last 1 or 2 decades is that the biomarker had developed for diagnosis of AKI at an early stage. At a stage when the serum creatinine is still normal, but there is a tubular injury, so we can detect in the urine substances which are secreted from the tubule because of the tubular injury when the GFR is still normal. So there are 2 things. GFR may be abnormal low, but there is no evidence of a tubular injury. That is seen in pre-renal AKI, because pre-renal is more of a hypovolumic AKI, where tubule are still not injured. So we may see rise in creatinine, but the marker of tubular injury will not be present. While if it is renal AKI, then we will see the marker of tubular injury in high concentration in the urine. But at the moment, this is more of a research tool and more for prediction of patients who develop more severe AKI. Otherwise, in terms of a intervention of patient management, we still rely more on a serum creatinine rather than on biomarker in the urine of tubular injury. Now, in terms of a chronic kidney disease investigation, other than biochemistry like urea, creatinine, sodium, potassium, we do imaging tests and try to find out the cause of CKD. And then we assess the potential complication of CKD in form of a anemia, bone disorder, and blood gas analysis. And very rarely in a patient of chronic kidney disease, we'll end up into doing a biopsy. Otherwise, if the clinical diagnosis of CKD is reasonably short, then biopsy is avoided, because neither it gives any much information, rather it is also risk of complication. Now then, once we have made the diagnosis, see the management. Now, management of AKI has got 2 broad concepts. One is we should prevent complication, and number 2, we should enhance renal recovery. So whatever tubular injury has happened, we give circumstances that recovery of that tubular injury is increased and renal function becomes normal. Now, in a broad principle are that we should recognize cause. For example, if there is a malaria-induced AKI, we should treat malaria. So we should determine primary cause and treat it, identify the correct reversible factor and correct them. We should prevent the renal injury and then continue to do the evaluation of the patient. Intermittently in this, if the patient needs supportive therapy, then supportive therapy is continued while the patient's tubule recover on their own. In a supportive therapy, what we need to manage is electrolyte, volume in the body, acid base. And because most of the drug are excreted from the kidney, in AKI as well as in CKD, the selection of the drug which is not nephrotoxic and the dose modification of the drug which is also needs to be changed. In terms of a nutrition, I just want to point out 2 things, that in acute kidney injury, we do not decrease protein intake. because we give high protein and good calories to cause early recovery of the tubular damage. While in chronic kidney disease, we restrict the diet to retard the progression. So in chronic kidney disease, there are two primary aims that we want to prevent from patient going from stage 1 to stage 5. And during that period, keep the patient asymptomatic. So in chronic kidney disease management principle is that we detect and treat acute factor, avoid nephrotoxic drug, adjust medication for the degree of CKD. Patient should be referred at some stage early to nephrologist for planning of the treatment. And then we continue the conservative treatment, and which include management of hypertension, bone disease, anemia, acidosis, or vascular access preparation. As I told you that in AKI, we don't restrict protein, but in chronic kidney disease, we restrict protein because protein is known to progress the chronic kidney disease. Course of the disease in short, there in AKI, two factors define the outcome of the AKI. Factor affecting the patient, previous health condition, what is the primary disease causing AKI, and severity of injury, and the response of disease by the patient. Increasing age, prolonged oliguria, presence of sepsis, hypercatabolic state, need of ventilation. These are the risk factors for AKI causing mortality. There are 5 outcomes of acute kidney injury. One is either there is a full complete recovery and person recovers completely, or it is incomplete recovery and patient of AKI goes into chronic kidney disease. If it is AKI on pre-existing CKD, then the progression of that CKD may become faster after the episode of AKI, or patient of AKI actually continue to require dialysis because he has gone into end-stage renal disease. And a good number of patients, approximately 30 to 50% patient, has got mortality in AKI depending upon the risk factor and the degree of severity of AKI.
Dr. Sanjay, can you just sum up, because
I will take 1 or 2 minutes more.
okay, that's fine.
In terms of a chronic kidney disease outcome, it is very important to know that if you take 100 patients of CKD, all does not go into end stage and require dialysis and transplant. And they actually succumb during that process of progression of disease by infection and cardiovascular death. It is important to prevent both AKI and chronic kidney disease. For AKI prevention, we need to prevent the better use of the drug and prevent sepsis and treat. While in chronic kidney disease, as a large number of patients are initially asymptomatic, we need to screen the high-risk group by proteinuria and serum creatinine, and this is the high-risk group which I have alluded before also. Other than the high-risk group, patient who present with edema, unexplained anemia, bone pain, or family history of a CKD should also be screened for chronic kidney disease. Because chronic kidney disease, the earlier we diagnose and intervene, more delay will be the progression of chronic kidney disease. So in sum up, what is if a patient present with a renal failure, we need to confirm that he has got kidney disease and low GFR, differentiate whether it is acute kidney injury or chronic kidney disease. In both the situation, diagnose primary cause, because primary cause can be treated. Otherwise, patient needs to be managed symptomatically. If it is not, primary cause is not known, then we manage symptomatically. We enhance recovery in AKI and prevent progression in chronic kidney disease. And in any stage during the follow-up of these patients, if the degree of damage is more, patient need intermittent dialysis. we need to prevent AKI and CKD in community and healthcare setting. With that, I finish my presentation and will be happy to answer any question related to renal failure.
Thank you, Dr. Sanjay, for this excellent overview. I don't see any questions in the chat box. Okay, there is one question. How nephrotoxic is rifampicin, as was shown in one of your.
Can you please repeat the question? How nephrotoxic?
How nephrotoxic is rifampicin?
Now, rifampicin is known to produce acute kidney injury, as well as rifampicin is also known to produce combination of acute kidney injury and proteinuria. And it is known to produce minimal change disease also. So these are the three. I mean, in terms of a renal failure, it is known to produce interstitial nephritis causing acute kidney injury.
So what essentially it can produce acute kidney injury and also chronic kidney injury, but not in all cases. It's, I mean, you can use the drug as a part of treatment of tuberculosis, but you have to be careful if you have any deterioration in rise in creatinine, any symptom, any findings, because that's what Dr. Sanjay is mentioning. In that case, you might have to stop the drug, but otherwise it is used very commonly for management of tuberculosis. It's a very effective drug as an anti-tubercular drug.
Another important question somebody asked was, what is the utility of diuretic in acute renal failure, acute kidney injury? Actually, diuretic, if you see, increases the urine output by acting on the tubule. And if the tubule itself are damaged, then diuretic is unlikely to improve the outcome. But in some of the conditions, diuretic helps in changing oliguric acute kidney injury to non-oliguric, and then the fluid management becomes easy. Second thing is that diuretic action also require oxygen for causing the transfer of the solute across the tubule. And once there is already injury, another need of oxygen can precipitate further injury. That is why in a established acute tubular necrosis or acute kidney injury, there is no role of a diuretic unless there is a pulmonary edema or you want to do vasodilatation of a pre-capillary.
Yeah, I think you are making the very important point, because I know when we were being trained, diuretics were used much more liberally, but now they avoid using diuretics because except for increasing the urinary output, the benefits are very limited, and it can produce some nephrotoxicity like AI, acute interstitial nephritis. There is another question, is there a role of blood urea nitrogen divided by creatinine ratio in clinical setup to differentiate pre-renal from the established acute kidney injury?
Yes, theoretically it is possible, because in a patient who is pre-renal injury, kidney will sense that there is a low volume into the kidney and try to absorb more urea from the tubule. And in that case, urea concentration in the blood will be higher disproportionately as compared to serum creatinine, and the ratio will be higher. So if there is a higher urea creatinine ratio, it suggests pre-renal. If it is low, then it suggests obstructive uropathy.
And there is another question, can loop diuretics precipitate chronic kidney disease?
Usually, a loop diuretic is a drug which is given for a shorter period. It can precipitate acute kidney injury. So if we say that it can cause AKI on pre-existing CKD, then the answer is yes. But diuretic itself causing chronic kidney disease is much less likely.
Yeah, because we use loop diuretics are the ones which are most effective in advanced CKD. So, but you have to be careful if you find any sudden deterioration, that some acute deterioration can occur. Any other question or anybody? If there are no more questions, I think to sum up, Dr. Sanjay Agarwal has given an excellent overview. What we have to realize that the definitions of acute kidney injury and chronic kidney disease, they have really dynamically changed in the last 30, 40 years. So we have to be aware of these entities. We have to diagnose them, and we have to understand that acute kidney injury and chronic kidney disease, they are actually also related. The previous concept that acute kidney injury is always reversible may not be fully true, and it is one of the important causes of chronic kidney disease. The other message which I need to highlight is that you must diagnose chronic kidney disease at an early stage to take care of this expanding outbreak of chronic kidney disease and chronic renal failure. Once again, I would like to thank Professor Sanjay Agarwal for this excellent overview of the problem of kidney failure. Thank you very much. And I give over to the next chairperson, Professor C. Aspen, to take over. Professor Aspen, please.
So thank you, Sanjay Agarwal sir and Professor R.K. Sharma for the wonderful session. So now coming to the next session, I would like to welcome chairperson for the next session on the approach to a patient with liver failure. So I would like to welcome chairperson. He's a renowned personality, Professor Rakesh Agarwal. He is director of Jawaharlal Nehru Institute of Postgraduate Medical Education and Research, Pondicherry. He worked previously as a faculty member at SGPJ Lucknow for around 30 years. He is fellow of Indian Academy of Sciences, Indian National Science Academy, National Academy of Sciences, and the National Academy of Medical Sciences. So, and he has been awarded a very famous National Bioscience Award. So I would like to, saving the time, I would like to welcome Rakesh sir. And I would also like to request Rakesh sir to kindly introduce Aipan sir. Yeah.
Good evening. Thank you for the kind introduction. I am grateful to the National Academy of Medical Sciences India for asking me to chair this session. And it's a pleasure to introduce our speaker today. Our speaker today is Professor C.E. Eapen. Professor Eapen heads the Department of Hepatology at the prestigious Christian Medical College at Vellore. And he has also been previously for a 5-year period, the medical superintendent of the hospital associated with the Christian Medical College at Vellore. Professor Eapen has several publications in the field of liver disease, and he has received several prestigious awards, including the Young Clinician Award of the Indian Society of Gastroenterology, the Sheila Sherlock Fellowship Award of the European Association for Study of Liver, and he has also delivered an oration, a prestigious oration of the Tamil Nadu chapter of Indian Society of Gastroenterology. He is a member of the editorial boards of several prestigious journals in the field of gastroenterology and hepatology. He's worked in the area of liver disease for last several years, and he'll be talking to us today about approach to a patient with liver failure. Thanks, Dr. Eapen, for accepting the invitation, and the floor is all yours, please.
Thank you, Rakesh, for the kind introduction. And I would like to thank the National Academy of Medical Sciences for giving me this opportunity to talk on approach to a patient with liver failure. So let me start by sharing my screen.
We can see your slides, Dr. Ipan. Thank you.
Okay. Fine. So I will be focusing on approach to a patient with acute liver failure. And what I would like to focus on is the definition of the syndrome, the etiology of acute liver failure, prognosis, and treatment. There are different bodies, expert bodies, which have defined this. Now, this slide refers to the definition provided by the Indian National Association Study of the Liver, the INASL definition of acute liver failure. So, in this definition, in ALF, the patient has no pre-existing liver disease and has developed jaundice. However, the added complication is encephalopathy. And invariably, the patient also has got coagulopathy. This complication occurs within 4 weeks of the first symptom of this illness. In contrast, a patient with acute liver injury or ALI, in contrast to ALF, does not have encephalopathy. This patient has otherwise the same criteria: no pre-existing liver disease, jaundice, and coagulopathy within 4 weeks. But there is no encephalopathy. So it's a presence of encephalopathy, a very serious complication, which defines the syndrome of ALF by its definition. Now, a person who gets an acute liver dysfunction, which can be due to different causes, for example, hepatitis A or hepatitis E, or a drug-induced liver injury, any of these can drive this disease, can cause the diseases, can either have one of these different spectrum of clinical syndromes. The person may have an ordinary type of jaundice, that is an uncomplicated type of acute hepatitis, where there is no encephalopathy or coagulopathy. Person can have acute liver injury, which I referred to at the definition of the previous slide. There is yet another terminology called severe ALI, severe acute liver injury, which is not very well defined. Some definitions give it as an INR of more than 2. And so that is yet another one syndrome which comes in this area. And there is acute liver failure. So uncomplicated acute hepatitis, acute liver injury, severe acute liver injury, or acute liver failure. Now, this INASL consensus statement says that, actually speaking, we can expand this even further. When you use the word liver failure, it can also encompass chronic syndromes. For example, cirrhosis could be considered as a chronic liver failure. We also increasingly recognize a combination of an acute event, acute liver failure, superimposed on chronic liver disease. We call it ACLF, acute on chronic liver failure. Now, in the acute syndromes, the severe ALI and ALF are syndromes where the mortality rate starts to go up. So in the first two syndromes of acute hepatitis uncomplicated or ALI, acute liver injury, there is no increased mortality. It's only a morbidity of the illness. But as per this particular study from USA, when the patient has severe acute liver injury, which is INR more than 2, and in their group study, majority of patients had paracetamol overdose, 23% of patients had progression to acute liver failure, died, or needed an urgent liver transplant. While people who have acute liver failure, the mortality increases to 60 to 80% with just standard medical therapy. So it's important to recognize the syndrome and then be aware of the natural progression of the illness in some of the disorders. There are yet other features of the classification. There is the time in acute liver failure, the time from the onset of jaundice to the onset of encephalopathy. The interval varies in different parts of the world. And there are subgroups to it as well. For example, the UK series described by Dr. O'Grady recognized a hyperacute presentation where the encephalopathy can happen within 2 weeks of onset of the jaundice. And paradoxically, the hyperacute presentation of liver failure has a better prognosis compared to the acute liver failure per se. Yet another definition here again from UK has got subacute liver failure, where the onset of the complication can be up to 26 weeks after the first symptom of jaundice. Now, moving on to etiology of acute liver failure. The causes, the etiology of acute liver failure is very different in different parts of the world. For example, in the Western countries, in UK and USA, paracetamol overdose is one common form of mode of committing suicide. And paracetamol overdose affects the liver and causes acute liver failure. And drug allergies. Person is taking a drug at a regular dose, at the recommended dose, but still gets liver failure. So this is idiosyncratic drug allergy. These are the two common causes in the Western world to get acute liver failure. In contrast, in developing countries like India and Africa, the causes of acute liver failure are mainly viral, hepatotrophic viruses. In India, outbreaks of hepatitis E is one big cause of acute liver failure, and sporadic hepatitis A and E occurring in adult population is again a predominant cause of acute liver failure. So there is a difference in what causes the acute liver failure in different parts of the world. Now, even within India, there are differences as to what causes this. In south and western parts of the country, southern and western parts of the country, ingesting rodenticide as a mode of suicide, which contains yellow phosphorus, is a popular form of trying to commit suicide. In fact, it is a big problem in these parts of India. This study, conducted in the state of Tamil Nadu, established that ingestion of rodenticide causing liver failure, liver toxicity, was the equivalent of paracetamol overdose in the West. In a 6-month period in 2019, from January to June, in the study conducted across 6 districts of Tamil Nadu by the Tamil Nadu chapter of the Indian Society of Gastroenterology, they could show that for every 1 patient of paracetamol overdose causing hepatotoxicity, there were 75 patients of rodenticide-induced hepatotoxicity. So this is a very large number. And in this 180-day study period, 2 of the medical colleges in the government sector had more than 180 patients. That means they had more than 1 patient per day. So the case burden is very large. This study showed that majority of the patients were young, mean age was 22 years, and of the 450 patients, the study documented in that 6-month time period, 1/3, 35% died or were discharged in a moribund state. So it's a problem of public health importance in these parts of the country. In that same study, only 1 patient could undergo urgent liver transplantation. So it again highlighted the fact that in majority of patients, urgent liver transplantation is not accessible in Tamil Nadu and possibly in most of India at the present time. Moving on to clinical features, the person who develops acute liver failure can have multiple organs being affected. And apart from the liver starting to fail, and there are very many functions of the liver, and some of these functions, when they start to fail, will manifest itself in the clinical syndrome. The dreaded complication really is cerebral edema. The brain swells within the closed compartment of the skull, and this is one big cause of death, the intracranial hypertension. There are different neurotoxins which have been studied, of which the most of the evidence points to ammonia ammonia is normally detoxified in the liver. When the liver fails and is not metabolizing ammonia, it accumulates in the bloodstream and it affects the brain, where the cells which are targeted is primarily the astrocytes, and astrocytes, when they swell up, they contribute to cerebral edema, intracranial hypertension, can cause brainstem herniation and death. Now, apart from cerebral edema, there could be acute kidney injury, the lungs could be involved, there could be marrow suppression, there could be cardiovascular. So it's a multi-organ failure is one of the consequences of unrelenting illness in acute liver failure. You should also keep in mind that in India, there are tropical infections which can mimic acute liver failure, which, so again, these causes should be evident once we look out for them. For example, as this paper by Dr. A.C. Anand shows, that severe falciparum malaria, dengue infection, leptospirosis, and scrub typhus are examples of tropical infections which can present and mimic like acute liver failure. Now, one of the clues are all in the clinical examination, history and examination, as well as the appropriate tests which we should then do to look for these infections. Fever is one characteristic feature of all these syndromes because these are infective states. It's not common to find acute liver failure having fever as a predominant symptom, but for these mimics. So that's one point to keep in mind. But there are other clues as well. For example, the person with malaria would have fever with chills, hepatosplenomegaly, etc. Dengue fever, headache, retroorbital pain, myalgia. Leptospirosis, fever, headache, myalgia, skin rash, conjunctival suffusion. Scrub typhus, fever, headache, myalgia, eschar, etc. So we have to be cognizant of this and be looking out for these infections, which may be more common in different parts of India. There are varied incidents of these infections as well. Now, which patient would go on to have worsening illness or not is a very crucial question, because the time window for all this is very short. So we have to know how is the patient likely to perform, likely to do, how is the patient, would the patient recover or not, is a very burning question. And in some patients, it's possible that urgent liver transplant may be possible. Who's the patient we should identify for this, or any other treatment possible? So prognosis is a burning issue. Now, there have been many studies looking at this. Let me try to use the analogy of our favorite sport in India, cricket. So, can we predict the outcome in acute liver failure? And there are different static and dynamic scores. So here is what I meant by cricket. I think most of the young people in the audience may be watching cricket or IPL or the different matches which happen. Now, increasingly, there are predictors of the match. We will know which team is likely to win. So it's possible that I may start at a static score, at a one-time score, which may be at the start of the match. And we say how strong each team is, who's playing today, which player is out with an injury, etc. And a dynamic score. As the graph shows, let's say this is a 20 over match. As it starts going towards 15 over 17, 18, it becomes very clear that we can be more and more sure who is going to win, who is going to lose. There are experts who maybe in the pre-match conference, they would be trying to give their opinion, a static score before the match, who they think will win. Of course, they will also keep saying it as it goes along, a dynamic score as well. In fact, even the crowd watching the match also seem to have a sense. Because, for example, at the start of the match, the stadium is full. Especially if the home team is losing by over 15, sometimes you may find that the crowd is leaving. They say, there's no point watching the match. The match is lost. So even the crowd seems to have a sense of predicting this outcome. So it appears that if there are dynamic scores of prediction, then that's how it goes. It's more and more evident to everyone how the match is coming up. Now, using that example in our head, let's look back at acute liver failure. The static scores which have been used are the MELD score, the model for end-stage liver disease, and the King's College Hospital criteria, which was proposed from the King's College Hospital in London in the UK many years ago. I'll be referring to this criteria a bit more in detail in a subsequent slide. In contrast, the best dynamic score has been developed in India from the All India Institute of Medical Sciences by Professor Subrata Acharya as a senior author in that. Now, in this study, which was reported in 2012, they prospectively derived which are the parameters which are likely to predict survival, and they validated that score in a subsequent group of patients. So there was a derivation cohort as well as a validation cohort. And the variables they had, the 4 variables which form part of this acute liver failure early dynamic. It's called the ALFED score, for presence of encephalopathy, INR, arterial ammonia levels, and bilirubin. So using this score, they have proposed this dynamic score. So when they analyze the data, looking at day 1, one can see that the area under the ROC curve had the MELD score was superior to the other scores here in predicting the outcome. But when it came to day 3, the same parameters were done. As you can see in the graph above, pointed out by the arrows, the ALFED score is moving more towards northwest of this graph, suggesting that it's more and more accurate in predicting the outcome. That's again shown by the numbers at the table at the bottom. So it's like the cricket match analogy. As it goes along, the illness, and it's like a 2020 match. The whole illness is over a few days, whether the patient survives or dies. It is more and more evident. And here are dynamic scores which can help us to decide, is the person starting to improve or not, and what more treatments are possible in the narrow time window that we have. Let me move now to treatment. The first treatment is to figure out, the first important thing is to know this patient has got acute liver failure. It's possible that such a patient is not getting recognized, and in the few hours or days which are lost in making the diagnosis, it may be of crucial importance to the patient. Now, once we recognize the patient is sick, this patient first has to be identified as the patient is seriously ill. The patient needs to be admitted in hospital, may need to be admitted in a high dependency unit, a HDU, or an intensive care unit or ICU, or in a closely monitored area in the ward. We look out for the etiology, what is causing the illness. If there is history that there is currently an outbreak of jaundice affecting 100 people or 1,000 people in the same locality, chances are in India, this is hepatitis E outbreak. We know that disproportionately, hepatitis E in an outbreak seems to affect pregnant women, and is more common, as well as more severe in advancing pregnancy. So that's one clue we would get as an example. A person who has been on a potentially hepatotoxic drug could go into liver failure. So once I make the diagnosis, which is a circumstantial diagnosis, that means I am on a drug which could be hepatotoxic, potentially toxic drug to the liver, and there is no other cause found. For example, the viral tests are negative. It's important to withdraw the drug. So thereby, to understand the etiology, suppose I am on an anti-tuberculosis medicine, I should be stopping that medicine. I may need to go on to the liver safe anti-TB drugs. If the cause of the acute liver failure is Wilson's disease, then I would be starting treatment for Wilson's disease. For example, zinc or trientine could be started in this situation. One of the clues for the uncommon scenario of acute liver failure caused by Wilson's disease is the peculiar feature in the liver function test, where the bilirubin level may start going more than the alkaline phosphatase level. So if the LFT reads like that, one has to consider the possibility of Wilson disease in a young child or a young adult. If it is hepatitis B causing acute liver failure, usually the IgM core antibody would be positive, it's important to start the antiviral drug for hepatitis B. We have very potent nucleoside analogs in this scenario. So looking out for the etiology is very important. So first is to recognize the syndrome and look out for the etiology. In pregnancy, this all can happen within hours or within a day. A person in late pregnancy starts going into acute liver failure, present acute liver failure. So there are syndromes which are related to pregnancy per se. One such syndrome is acute fatty liver pregnancy, or AFLP, or the HELP syndrome, hemolysis, elevated liver enzymes, and low platelets, which can go into acute liver failure, where urgent termination of pregnancy, delivery of the baby is a treatment. So it's crucial to figure out try to understand what is the etiology driving the illness and treat accordingly. Now, this patient, once admitted, also would need the routine care of a critically ill patient, which really refers to support as needed for different vital organs which may be affected. So these are all the important first steps to do. So I think I have covered this. We look for the cause and treat appropriately. We have to manage a critically ill patient. So what the routine management of a critically ill patient needs to be done. So there is nothing more specific about that. It's like any other patient with internal medicine where in critically ill, how would we approach? What about, maybe I'll focus on cerebral edema a bit, because that is high mortality, a complication which can lead to death. Now, in this cartoon, the authors show that the causes of death in patients with acute liver failure, the main causes are intracranial hypertension due to cerebral edema. The patient is prone for bacterial infections because there seems to be a state of immune paralysis in the course of the illness, as well as multi-organ failure. Increasingly, with treatment of cerebral edema, the deaths due to cerebral edema is decreasing in the Western world, and multi-organ failure is more of a problem. Now, in India, maybe infections are more, cerebral edema is a problem. So, but these three big causes of death we need to be aware of and treat accordingly. Now, the grade of encephalopathy in acute liver failure can be classified by the West Haven criteria, of which grade 1 is, for example, a person restless or a reversal of sleep pattern. And grade 3 is a person is drowsy, and grade 4 in coma. The signs of raised intracranial pressure can also be recognized in more and more severe illness as it goes along. What are the management principles to prevent or treat these complications of the central nervous system in the ALF patient? The patient is nursed in a posture where the head end of the bed is raised by 20 to 30 degrees. We have to correct the fluid balance, but at the same time avoid volume overload. We target a mean arterial pressure of 60 to 70 millimeters of mercury. One strategy is to hyperventilate with an aim to reduce PCO2, which may cause cerebral vasoconstriction and lead to try and reduce cerebral edema. To prevent surges in the intracranial pressure, minimize head turning. In those who have more advanced encephalopathy of grade 3 and 4, We intubate the patient, ventilate to protect the airway to prevent aspiration. We minimize suctioning of the endotracheal tube and less of stimulation of the ET tube on suctioning. Can also give osmotic agents, osmotherapy, like either hypertonic saline intravenously or mannitol to try and cause shrinkage of the brain, because brain swelling in the closed compartment of the skull is what is the cause of death in cerebral edema and intracranial hypertension. Now, the INASL recommends in this regard that in early encephalopathy, it's important that grade 1 and 2, important to avoid the use of sedative drugs like benzodiazepines, because most of these drugs are metabolized in the liver, and in liver failure, they start to accumulate and can by itself worsen encephalopathy and trigger respiratory depression. However, as I mentioned, in grade 3 and 4 encephalopathy, we intubate. Endotracheal intubation is done mainly to prevent lung aspiration from secretions. Non-invasive tests for cerebral edema can be measured by looking at the optic nerve sheath diameter. Prophylactic antiepileptics are not recommended, but if needed in a person who's had a seizure, drugs like levetiracetam may be preferred, which these are less hepatotoxic. It's shown in ALF, in acute liver failure, non-absorbable antibiotics or lactulose do not improve survival or encephalopathy. Moving on to liver transplantation. So urgent liver transplantation is required to save lives in a patient who is worsening with acute liver failure. So this is the criteria derived from King's College in London, used world over, where they showed that their big problem in the Western world is paracetamol overdose. So ALF due to paracetamol overdose, there are a series of criteria which predict poor outcomes and thereby the need for urgent transplant. And strangely, this criteria do not have bilirubin, while the non-paracetamol causes of acute liver failure has got, again, different criteria, including bilirubin as well. So these are criteria which have been used, and patients who meet this criteria are eligible for supra-urgent listing for liver transplantation in a cadaveric program. So they would get the first priority to get a liver, donated liver allotted to that patient across regions of UK. In India, this works in different states as well. For example, in Tamil Nadu, a patient who's meeting this criteria and listed for urgent liver transplantation would get the next first liver, which is donated across Tamil Nadu for in a cadaveric donation scenario. Now, there are other criteria as well. For example, from France, the Clichy criteria and Japanese criteria, etc., to decide on listing criteria for urgent liver transplantation, acute liver failure. This is data from the ILBS hospital in Delhi, where they show the outcomes of living donor liver transplantation in acute liver failure, as well as the safety to the donor. So of 410 patients who underwent live donor liver transplant in this 8-year study period, 15% was done for acute liver failure, 61 patients, all met King's College criteria. The commonest etiology was viral. 70% of patients were on mechanical ventilator. In this series, there was no donor death, which is one of the risks with a live donor program. And in those patients who met the King's College criteria but did not have liver transplantation, only 23% survived with medical therapy alone. While those who underwent liver transplantation in acute liver failure patients, the 5-year survival was 66%. Lastly, I may just talk a little bit about some newer therapies which are now showing encouraging results, and one such treatment is plasma exchange. Now, plasma exchange refers to a combination of removal of plasma from a person in a state of ill health, that is plasmapheresis, and replacing volume for volume, or in liver failure, we prefer to replace with fresh frozen plasma or FFPs. Different volumes have now been used and reported in plasma exchange acute liver failure. This is the landmark paper from Europe. Larson et al. Showed that 4 times the plasma volume, about there's a large amount of plasma. About 10 liters mean plasma per day was exchanged, while from ILBS, standard volume plasma exchange 1.5 to 2 liters, or 2 times the plasma volume. It's about 2 liters per day was exchanged. And in low volume plasma exchange, half the plasma volume. In an adult, the plasma volume is about 2.5 liters. So 1.2, about 1 to 1.5 liters is primarily the protocol used at CMC Vellore in these syndromes of liver failure. This is the landmark paper from the Europeans, 3 European countries, which showed that especially in patients who were not having an urgent liver transplant done, there was a 10% increase in using high volume plasma exchange in increase in survival by using high volume plasma exchange. Because this randomized control trial was done very well and the data was statistically sound, the American Society of Apheresis has recommended as a grade A recommendation, category 1 recommendation, that high volume plasma exchange, or PLEX as we call it, could be advocated as a standalone therapy without liver transplantation for acute liver failure. So, this is a randomized control trial from ILBS Delhi, where again, there is better 21-day survival compared to standard medical therapy in acute liver failure patients. Now, Dr. Acharya in this paper refers to the fact that in India, about 1,000 patients undergo liver transplants per year, mainly live donor, and of which maybe 5 to 7.5% is done for acute liver failure. But as I referred to, the Tamil Nadu study showed that, and the study in Tamil Nadu on rodenticide poison estimated that in 1 year alone, there would be 500 patients who would die in one state of rodenticide poisoning alone. So one can see the gap between the availability of urgent liver transplantation in India. So a bit more positive news is now coming out in this area. This is data from Amrita Hospital in Kochi. We're calling it the Kochi criteria now, where in 2015, they showed that in rodenticide-induced acute liver failure in people who had very high levels of liver damage by these criteria, they looked at their data set. And of patients, 8 patients who met this criteria on standard medical therapy, no patient survived. While of 12 patients or 14 patients who met this criteria and underwent urgent liver transplantation, 86% survived. Now at CMC Vellore, now we have been using low volume plasma exchange, and we find that in this group, none of the patients opted for liver transplantation. And there is 62% survival with low volume plasma exchange. In children, the survival seems even better, but the numbers of patients are very small in the series. So that's the same data in another pictorial form of representation, that patients meeting Cochin criteria with a diagnosis of rodenticide-induced acute liver failure, when they underwent low volume plasma exchange, there was a 75% survival in this group. In fact, it is just very recently, there's an editorial by Larson, who did the first study on the high volume plasma exchange, where he also appreciates the low volume plasma exchange, which is uses less resources and maybe more appropriate in our country to treat these patients. So I think I will end there, and thank you, and happy to take any questions if there are.
Thank you, Professor Eapen. We don't have any questions yet, but I'm sure they'll come. People must be still absorbing the excellent details that you provided of definition, diagnosis, prognosis, and treatment. So here we are. So here is the first question. How safe and ethical is a re-challenge with anti-tuberculosis drugs in a person with suspected drug-induced liver injury?
Thank you. That's a very good question, serious question. Now, usually we try to avoid the drug which we think caused the problem. But there are some situations where we have no choice and we have to restart the drug again. So that's where the question is. Now, generally what is done is once we identify this drug be causing the problem, and I must first start with saying that often it's not identified, not recognized. Neither the treating physician nor the patient realizes that the medicine I'm taking every day is causing the problem, and maybe I took it for another 2 weeks. But once we recognize it, we would go on to non-hepatotoxic drugs, the hepatosafe drugs, which are ethambutol, quinolones, streptomycin. These are the drugs which we can use. But then comes a difficult question: can we re-challenge these drugs or not? So the answer would be, first is, how severe was my initial liver injury? Was it only acute hepatitis, or did I go into acute liver failure or severe acute liver injury? Now, let us assume it was only severe acute hepatitis. It's possible that if the liver function normalizes over time, I may wish to restart it one by one. Now, this study has been done elegantly. One study addressing this exact question was done between SWIMS Tirupati Hospital and AIIMS Delhi, where Professor Govind Makaria was a senior author, and they had 3 regimes they followed in restarting the drugs. So they started it. One is by the European recommendation, other one is by the American Thoracic Society, etc. There were 3 different regimes. And one was started one by one, drug at a time was added on, versus all 3 drugs added on together. And the study concluded that there was no difference in outcome. So these were not patients with acute liver failure, they were just acute hepatitis per se. So this difficult question has been addressed. And in fact, there's a very nice example of addressing a relevant clinical question in our population by a well-conducted study. The data is very good, and it guides us, helps us to treat the next patient that we see. And I must say at Vellore, we often look up that study to make that call. What shall we do next? We may not necessarily do what is there in the study, but it guides our thinking. I just want to address that question. Thank you.
And if I may add to that, very often anti-tubercular treatment regimen has had more than one hepatotoxic drug. And by doing this, we are able to at least give one of them, if not all of them or 2 of them, and that's an advantage. And very often patients can get a drug like INH or rifampicin, which are very effective. So there is another question. Are there any reports of liver failure with terbinafine? I know it's a difficult question to answer offhand.
Okay, so the answer is like this. First is, anyone who's gone through pharmacology exam knows, if the examiner asks, what are the side effects of a drug? You say nausea, vomiting, diarrhea, and jaundice, it's pass. The examiner cannot fail you, because the reality is with any drug, there would be hepatitis. In literature, if you look it up, any drug. So it's a pass, is assured. Okay, but you have to say this point. Now, I'm using the same logic in this scenario. That's how I approach it. So when asked the question, as Rakesh mentioned, I wouldn't know the answer offhand. But my first principle is any drug can cause. I'm a doubting Thomas. Okay, I suspect. Secondly, I would look it up. There are now enough accesses available. For example, liver tox is one such information available, constantly updated, where we know are the reports of liver toxicity and how severe they are and what are the recommendations on that. So that's how I would approach it. I do not know the answer offhand, but these 2 things remain.
Okay. As of now, we don't have any more questions, but I think we'll wait for a little while. So let me go back to the question of static versus dynamic prognostic models. Do you really think, dynamic models are any better? Because to me, if you come to know something 3 days later, you already, you anyway know. So should we really be emphasizing the dynamic models?
Thank you. I'll answer that question. So with the experience that we have, I shared a bit about the emerging modality of plasma exchange. Now we are in a center where there is currently, we don't have an urgent live donor program. So urgent access is not there. So decision making is very easy. The family is counseled and they say, okay, we do not want live transplant. We're not doing that. We do not want urgent liver. That option not coming up. So we do plasma exchange. But there are many centers in the country which have a live donor program. In those centers, this particular question you asked is a burning question. So should we do plasma exchange or not? We can do it. There's not much harm done. Maybe there's a benefit. 2 sessions done. Should we continue with the plan for liver transplant or not? And the window is very short. So in such scenarios, the answer is not known. And just today morning, Professor Julia Wenden again from King's College was telling us that she would go by the day 2, day 3 bilirubin levels and look at the delta change. And that data is not yet there, but it's starting to come out. From China, largely, it's already come. Large series of plasma exchange done for hepatitis B induced ACLF more, acute and chronic liver failure, where delta bilirubin seems to point the way. So answer is yes. So surely yes. So which model is another question, but we need dynamic.
So we have more questions. In a patient with hepatic encephalopathy, do you think there is a benzodiazepine that is safer than the other congeners?
Okay, I like that question. I'm a campaigner, I'm an evangelist on this question. Now just imagine there is a country, there is somewhere in the world where there is no option of urgent liver transplantation. Or just imagine there's a state in India where there is so. Now, actually, the reality is it's most of India. It's only the minority are able to access urgent liver transplantation. Now, here we want to max survival by any means. So the recommendation which has been brought out by Tamil Nadu chapter of Indian Society of Gastroenterology says, do not use any sedative. Or if you have to use it, restrict the use. This has now also been brought out by the National Health Mission, again in the Tamil Nadu chapter, almost similar to snake bite neurotoxicity. In snake bite, the National Health Guideline says, do not give sedatives. Again, the person is anxious, for example, there, but we do not want to risk respiratory depression, and we wouldn't know it. When the person goes on ventilator, it's another sequence of events are turning bad. So I would very, very strongly support this point, especially from that perspective. Now it's again more difficult. Suppose there's an option of urgent liver transplantation, and I'm transferring the patient 100 kilometers, the patient who's sick, to a center where there's urgent transplant possible. There, this decision is not so easy. But for most of India, the decision is very easy. I would rather not give any sedative, but I would give it if I have to intubate someone. That's different. So person became sick, more and more sick, then it's a correct thing to do. Otherwise, it's again life or death. So answer is no. No benzodiazepine is safe, or no sedative is safe. They are all metabolized in the liver. So I'd rather not use it. That's but currently in India, that's not the scenario. People are not, it's not yet figured out properly. So we have to have a clear understanding about this. And this is a no-cost intervention to save lives. We already experienced that in our center.
So there is a much broader question, and I think a question which should be of interest to a wider audience. Can you explain something about MELD score versus Child-Pugh score versus LFED score? Which one should be used where? Which one is better? Which one is worse? Or should one say, what situations is one better and what situation is the other one better?
Thank you. As Rakesh mentioned, that's a very interesting question, important question, as well as maybe for some exams useful as well. You may get some MCQs around this. So MELD score, or what's now called the model for end-stage liver disease score, was derived by Professor Patrick Kamath in the Mayo Clinic in USA. He derived it initially to predict how many patients would survive after TIPS procedure. However, it's now been found to be a very potent set of variables with the appropriate statistics, which predict survival in different syndromes of largely in chronic liver disease. So in cirrhosis, it's used as a criteria to list for liver transplantation. Let me give an example. MELD of 12 or MELD of 13 or more is the criteria needed for liver transplantation. So suppose a patient comes, I've been advised liver transplantation, diagnosed with cirrhosis, but the MELD is 9, let's say. By the criteria, no, doesn't sound good. You do not meet the criteria. Unless there are some exceptions to MELD, that's another story. For example, a person may have a liver cancer and still have a low MELD. Then you can still be come under MELD exception. So yes, it's useful in very widely used in this scenario. Now, it has also been then used in acute liver failure, though the initial data set was not for that, was not derived for that data set. The child score and the cube modification later was largely to look at, again, prognosis in patients with cirrhosis. They have stood the test of time. And again, every medical student knows these, and they're easy to use in those. The Alfred score, the challenge is arterial ammonia, I think. Routinely, that's not done. And so that's where that stands. But it proves the point. And I made the cricket analogy because we are all cricket fans. Because towards, as it goes along, it's very evident who's going to win, who's going to lose. So we need dynamic scores. And the dynamic is again referred to as delta changes. And delta bilirubin, even we have a data set now showing the same thing with drug-induced liver injury. Oh, sorry, in hepatitis B, we've shown it here as well, where fall of bilirubin level of 10 milligrams per cent after plasma exchange seems is the predictor of survival. So like that. So it makes sense. You have to look out for them and derive them. Yeah.
Thanks, Epan. So, Dr. Epan, I don't see any more questions from the audience. If there is any other final remarks you wish to make, otherwise, I think yeah.
Well, thank you. Maybe I may just conclude by highlighting some of Professor Rakesh Agarwal's area of work. He dreams about hepatitis E. He is one of the world authorities in hepatitis E, which is the biggest cause of acute liver failure in India. So his work has been largely in preventing this illness. And that, again, is the correct approach to do. Prevention is better than cure. And so it is a big problem in India. So it's about increased, better sanitation, clean water, as well as newer vaccines. And we're looking out for the new randomized control trial, which is about to start or started, Rakesh? May I ask?
About to start.
About to start for the use of hepatitis E vaccine to prevent this illness in our population. So that's yet another aspect. Prevention is important, and hepatitis E is our problem, and thereby it's going to have a huge impact on this particular research. Thank you. I would like to thank the National Academy of Medical Sciences for giving me the opportunity to present. Thank you.
Thanks, Dr. Epan. And as I said in the beginning, it's going to be, I had said at the beginning, it's going to be a wonderful lecture, and that's exactly how it turned out to be. Thanks a lot for taking us through various aspects of acute liver failure. And I'm sure that the audience enjoyed it. Thank you. And I'll hand the baton back to the organizing team. Thank you.
Thank you, sir. I would now like to request Professor Ajay Kumar Sood, sir, Deputy Secretary, National Academy of Medical Sciences, to deliver the vote of thanks.
Thank you. It is indeed my pleasure to thank the esteemed speakers of this evening, Professor Sanjay Agarwal and Dr. C.S. Epan, sir, for making this presentation and giving practical tips to our students. I hope that these tips will be very useful to them for their clinical management as well as for their examination. So thank you, sir. We are grateful to our chairpersons, Dr. Professor R.K. Sharma, sir, and Dr. Rakesh Agarwal, sir, for chairing and organizing the discussion. We are grateful to you, and we look forward for your blessing in future also. As far as the students are concerned, we make appeal to all the students to please send your suggestions and your feedback to our about this program. And your feedback is important for us for future organizing the lecture series. In this present lecture series, which is till March, we are going to focus on emergency situations. So next session, which is due on 19th of February, we'll be discussing about approach to a patient who is unconscious and a patient who is having poisoning. So please encourage your participants or your other fellow colleagues to register with us, and please do join us next time. And I would like to also place on record the efforts of the organizing team, comprising of the AIMS team from AIMS, Dr. Preeti, Dr. Jaswant, Dr. Minali, Dr. Chipi, and Dr. Dinesh, as well as the support team from ILBS, comprising of Mr. Gaurav and Mr. Mitesh. And of course, at National Academy of Medical Sciences, the support provided by our Secretary, President, and of course, Administrative Officer Nirmalji, our IT expert Raviji, and of course, Program Executive Mrs. Madhuri. So we are grateful to all of you, and we look forward to meet you again on 19th of February. Thank you so much.
Thank you, sir. I declare this today's session closed.